Welcome to Quick Medical Review. Today, osteoarthritis in under 5 minutes. Let's go. Buzzwords first. Wear and tear degenerative joint disease. DIP joints Heberden nodes. PIP joints Bouchard nodes. Joint space narrowing osteophytes subchondral sclerosis on X-ray. Worse with activity, better with rest. Acetaminophen first-line treatment. Let's break it down. Osteoarthritis OA. The most common joint disease worldwide. It is a degenerative disorder, not an inflammatory or autoimmune disease. The articular cartilage progressively breaks down from mechanical wear and tear. Risk factors: age, the strongest risk factor; obesity, prior joint injury, repetitive joint use, female sex, and genetics. Joints most commonly affected: knees, hips, DIP joints of the hands, first CMC joint of the thumb, and the lumbar and cervical spine. Notably, OA spares the MCP joints and wrists, which helps differentiate it from rheumatoid arthritis. Presentation: joint pain that worsens with activity and improves with rest, the opposite of inflammatory arthritis. Morning stiffness lasting less than 30 minutes, brief compared to RA, which lasts more than 1 hour. Crepitus on movement, decreased range of motion, bony enlargement of the joints. Classic hand findings: Heberden nodes, bony enlargements at the DIP joints. Bouchard nodes, bony enlargements at the PIP joints. Remember H for Heberden and higher DIP, B for Bouchard and below PIP. X-ray findings: joint space narrowing osteophytes, bone spurs at joint margins, subchondral sclerosis, and subchondral cysts. These findings are characteristic but do not always correlate with symptom severity. Labs normal. ESR and CRP are not elevated. Rheumatoid factor is negative. Synovial fluid non-inflammatory, clear, viscous, white blood cell count below 2000. Treatment: stepwise approach. Non-pharmacologic weight loss, the single most effective intervention for knee OA. Exercise: low impact swimming, cycling. Physical therapy. Assistive devices: canes, braces. Pharmacologic: acetaminophen first line for mild to moderate pain. Topical non-steroidal anti-inflammatory drugs: diclofenac gel effective for knee OA. Oral non-steroidal anti-inflammatory drugs: ibuprofen, naproxen for moderate pain. Use the lowest effective dose for the shortest duration. Intra-articular corticosteroid injections for acute flares provide temporary relief. Duloxetine, an SNRI approved for chronic OA pain. Surgical total joint replacement arthroplasty for severe OA, not responsive to conservative management. Most commonly done for knee and hip OA. Avoid opioids for long-term management. Glucosamine and chondroitin evidence is mixed to negative. Exam: Pearl OA is the most common joint disease. Pain worse with activity, better with rest. Heberden nodes at D, Bouchard at P, spares MCP, and wrist those suggest RA. X-ray shows joint space narrowing and osteophytes. Weight loss is the best intervention for knee OA. That was osteoarthritis on Quick Medical Review. Study smart, not hard.